my RCPCH. Within the time, I also completed my MRCPCH exams. And then currently, I work in various roles within the hospital that I work. I'm a simulation instructor for pediatric and neonatal crisis. I'm an APLS instructor, I involved in rota management, induction training, quite a few things that I've done. The PAU lead for my hospital, my department, and then very importantly, I'm part of the soft landing team, which supports international doctors. And I've taken up the role of supporting people going through the CESR process, giving my experience having gone through CESR very successfully. So I would like to just share some myths. Sorry, could you move the slide, please? Yeah. I would just like to share some myths. In fact, before I go to the myths, I just want to share a short story about myself and what my CESR journey was like. So, of course, just like many of you, as I started my journey trying to apply for CESR, I attended lots of webinars and conferences and teaching sessions and different things just to learn more about what the whole portfolio / CESR pathway was about. And I remember in May 2023, I attended a BMA conference. And when I came out of that conference or seminar, whatever you would call it, it was like a 3-4 hour thing. When I came out, I was extremely confused. I didn't know how to begin because the information was just too much, one. And then the information was coming from people who hadn't, who hadn't done CESR. They just knew about CESR. They knew what the process was like. They hadn't done it, and they were just giving information based on knowledge they had. I was overwhelmed. I was confused. I was frustrated, and I still remember that I came back home and I cried, and I was wondering how on earth would I complete this pathway. So that was in May. And then sometime in September, I heard there was another CESR thing happening. This was done by doctors in training, if I remember. And I decided I would attend. Honestly, by that time, I had actually lost hope about CESR because it seemed impossible. But anyway, I attended this conference. This was in September. And when I attended, interestingly, they didn't talk too much about the pathway. Rather, they talked about what your career anchors were, what your reason for doing CESR was, what CESR meant to you, what you would do with the CESR, I keep saying CESR, what you would do with the outcome of your portfolio pathway if you're successful, what you would do if you were not successful. And just hearing about it and thinking about it slightly differently, I was less overwhelmed. And I came out of that, it was precisely on the 29th of September. I came out of that conference on 29th of September. And from 29th of September till 29th of November, when I actually did submit, that was 2 months. Within 2 months, all the things I had found so difficult to do, somehow I just had energy and the mental ability to be able to do it because I wasn't being told what to do. Rather, I was being asked, why are you doing what you are trying to do? What's the purpose? What's the reason? What do you aim to get out of it? And I just found that that approach was so much easier and better because then I really took ownership. I wasn't being told you have to submit this evidence or that evidence. Rather, I realized that, all right, I'm trying to accomplish this for this reason, and this is what I need to do. And it just made my journey so much easier. And within a space of 2 months, I was able to put all my evidences together, organize them, and able to submit and had a successful outcome. So my aim and hope today is that each one of you would leave with a sense of being in control of your journey rather than feeling overwhelmed. I want you to see examples of what we have done or what I have done and feel that, yes, I can do this and have the reason why you're doing this for yourself. So if we are able to accomplish that, I'll be very happy, with what we've done. So some myths about CESR having my own successful outcome was that one is extremely difficult to do. Yes, it's a bit, I won't say it's difficult. It requires a lot of time and attention, but it definitely can be done. I've done it. Jazz has done it. Wakas has done it. Several others have done it, and you can definitely do it. So do not be discouraged at all. The second thing is that People think you must work in several hospitals in the UK to have a successful outcome. That's not true. I've worked at one trust since I've been in the UK. And in that, my one trust, I was able to get all the competencies that I needed. For people that I've met face to face and had interactions with, I've given them tips and ideas on how to get the competencies. What you need is to demonstrate the higher learning outcome competencies across the various domains. It doesn't matter where you get it. You just need to demonstrate that you have it. And the third myth is that, and I don't know where this comes from, but people say you can only be recognized as a consultant in your local hospital if you go through CESR pathway. So that's, I don't know where it came from. But once you've completed CESR, you're registered on the GMC Specialist Register, and you can apply for a substantive consultant post absolutely anywhere in the UK. There may be a few restrictions in certain countries, but as far as you're in the UK, you can apply anywhere at all. All right, so having said that, I'll go to the first thing which I want to talk about. So the SSG. So two documents you must be very familiar with: the specialty specific guidance for pediatrics, as well as the curriculum. You kind of need to know what am I matching this against. And by the way, my CESR was in general pediatrics, and Jazz and I are talking about general pediatrics. So we don't really have the information we're giving is more for general pediatrics. However, when we do get to the question and answer section, if you have questions about a specific specialty, I'm sure that within the room here would have some answers to be able to give you. And anything we haven't got answers for, we'll look for the answers and we'll help you out. So we're all familiar with the 11 domains of pediatrics, which are what is outlined here. So my top tips generally with being able to, with starting your process is, first of all, create folders for each of the 11 domains. And then within each of the folders, I'll show you what mine looks like. Within each of the folders, regularly place evidence as you get it. Regularly place evidence as you get them, and things like, sorry, just please move to the next slide. Yeah, thank you. So things like if you've done something on your e-portfolio, on the e-portfolio, there is no link. Your Kaizen e-portfolio and your GMC application, they don't speak to each other. The systems are not connected. So if you've done something at that time, just download it and save it into the relevant folder. Then organize the evidences. After you've got all the evidences you want in the different folders, begin to organize them into different categories. That's what I'm going to be talking about today. And I want to highlight here, if you are aware, first of all, the GMC, the application for your portfolio pathway is done on the GMC website, number one. And then number two, you're going to be uploading about 150 documents uploads. And if you divide it, if you have 11 domains and you divide it, that means that you shouldn't have more than 15, actually like 14, between 12, generally between 12 to 15 documents in each of the 11 domains. So once you've gotten all your different evidences in each domain, so let's say you have domain 2, for instance, communication, and you have reflection, you have a case-based discussion, you have different things within that domain. As time goes on, you're gathering it into the domain. After a while, you need to begin to organize it, but don't organize it into more than 15 categories maximum. Then you also need to give them appropriate titles so that it's easy to identify them. Otherwise, if you just say reflections, you're going to have reflections in perhaps all the 11 domains. How do you know which reflection it is? So it's good to give it a title that you can easily identify later. And another top tip is that anonymize the documents as you get them. For instance, if you have a patient's note that you want to use as one of your evidences, make sure that you've anonymized it at the time you're getting it so that you don't need to go through the stress of anonymizing it later because it gets too much. I found myself in that situation, but I was very fortunate. I had one of the secretaries in the department who helped me to anonymize some of the data. Otherwise, it can get quite stressful at the end. So let's go down now into the next slide, please. So example, yeah, I'm on the right slide. So examples of evidence organization. So if you look on the left of the screen, you'll see this was my folders, all the domains and documents I needed to submit. This is what it looks like on the GMC website. So on the GNC website, the first thing they will ask is your CV, then they will ask about details of posts and duties, then they will run through domains 1 to 11, asking for all the evidences within those domains, and then verification of the evidence. So I've created all these folders. What I was then doing is, in each folder, if I did something that I felt was relevant to that domain, I would just throw it in. So I was just constantly throwing in different documents into each of the folders. I then went back into each folder after a period of time and started looking at all the evidences that I had. I started looking at all the evidences that I had and started grouping them into what seemed relevant. So on the right-hand side is an example. You can see domain 2 documents, and in domain 2 documents, I grouped them into CBDs, communication with parents, discharge letters, docs, Kaizen, referral letters, just as you see there. And I think in total, I had about 12 groups within this domain. So what I then did is, when it was time to upload the documents onto the GMC website, when I opened my registration, I literally just opened my folder. So I would open domain 2 and then just start uploading these documents in the way that they had already been arranged. They had been arranged, they had been anonymized, and they had been properly labeled for me to upload. So if we go straight into domain 2 now, let's look at some examples there. So this, I literally just copied and pasted from the specialty specific guidance. These are the things that they are looking for in domain 2. They want your knowledge, skills, and experience, and they give you suggested evidence. I'm sure all of you, or many of you, probably have looked at the specialty specific guidance. So they give you examples of suggested evidence. Take note that it says suggested evidence, not mandatory evidence, which means that these are suggestions on the kind of things that you can submit. You may have something slightly different, you may have more than what they've said, or you may have less than what they've said. You don't have to put every single thing. Sometimes people get bogged down by thinking that they need to put every single thing that has been said there. You shouldn't put every single thing if you don't have it. And if you have more, you can add. But what you should focus on is that they've asked for the knowledge, skills, and experience and given examples there. You should show evidence that covers what they've asked for. So let's look at the first one, for instance. They said the knowledge, skills, and experience they want is that you can effectively communicate with an MDT with children, young people, and their families, where there's a range of differential diagnosis and management is uncertain. So this is like thinking about like a complex patient you've managed. Can you think of any complex patients that you've managed that there was a range of differential diagnosis? You had to have MDTs, talk about the patient, and then finally come to a conclusion and treat that patient. If you have something like that, whether it's a medical report or is a case history or is a discharge summary, anything like that would fit into this category. So you can pick something, you've addressed what they want here. If you look at the next one, they said models and teaches effective active learning skills in consultation with children and young people. Have you done anything that can reflect that? If you have, that document would suffice. So you don't have to do every single thing. That's what you just need to get in your head, please, so you don't stress yourself too much. So this on the next slide now, I've just talked about the various kind of things that they want you to show. So the various types of evidence in this domain include clinical correspondence, medical reports, case histories. This is just a summary really of all the things they've asked for in the previous, noted in my previous slide. MDT meetings, referral letters, correspondence with patients, communication in palliative and end-of-life care settings. So these are all the type of things that they're asking for. Now, as you go on in your work day to day, you would have come across all of these or many of these in lots of your circumstances. Handover documents, for instance, there's nobody who doesn't do handovers. As long as you're working within the NHS, there must be one form of handover or the other. Maybe you've attended a child death review meeting, or you've been involved in a CDOPS or something. All those things come in within this domain. All those are the types of evidence. Some of them can come out as work-based assessments. Some can be HATs, some can be docs, some can be your reflections, some can be CBDs, whatever. All those are the types of are the types of evidence for this domain. What you then do is, if you just go to the next slide, I've given some day-to-day examples of communication that you do. Sometimes you actually don't even think about it that you're doing these things. So for instance, you're in A&E and you've explained a WIS plan to parents. That's a type of communication. If you write a reflection on it, or you do a mini KEX, or you do a DOPS, that's an evidence you already have. Teaching parents how to use adrenaline auto-injectors. Discussing a patient in an MDT meeting, whatever type of MDT meeting, be it an X-ray meeting, a renal meeting, or whatever, that's a piece of evidence. Handover, discussing results with parents, or teaching a junior colleague in A&E or by the bedside, or writing a clinic letter. All these are types of evidences. So to be honest, within a day, you've gotten literally almost everything that has been asked for. You just now need to organize it and put it in a form or an order that makes sense for you to submit for your application. So if you go to the next slide, I've now given a suggestion. This was how I did mine. So categories. So what you can then do after you've gathered all the evidences into domain 2, what you can then do is you then group all your clinic letters together. And for the clinic letters, I've given an example that you could put like complex patients that you've managed. And this evidence, you can actually also use it for domain 4, because domain 4 is patient management. So you don't have to put all the clinic letters that you've done. You can select maybe 2, 3, or 4, whatever number that you think represents the work that you've done, that shows the breadth of your work, or maybe it was a complex case or something. You put the clinic letters together and you can just label it clinic letters discussions or communication, whatever name you think is most appropriate for it. So clinic letters can form one group. Referral letters can form another group. So that's already 2. Discharge summaries of complex cases that shows how you communicated with parents or with allied health professionals. That's another group. And again, you're not going to submit all the discharge summaries you've done, just a select few discharge summaries. And as it's always said, the quality is what is more important than the quantity. So if you can get a discharge letter, a discharge summary, maybe 2, 3 discharge summaries that you have personally written that shows like a very complex case that needed further follow-up on discharge, needed to have several meetings prior to discharge, needs follow-up with different specialties, needs several medications, some of which the GP needs to prescribe. That kind of complexity is a good clinic letter. And if you can produce 2 to 3 of those kind of letters and put it together as one document, that's discharge summaries done for you, and it has addressed the requirement for that domain. Clinical correspondences. These can be email correspondences, such as maybe emailing another specialty about a patient, maybe a patient with abdominal pain of unknown cause. You sent an email to gastroenterology to have a discussion or something like that. That's a piece of evidence. Putting it all together is one piece of evidence. The one I would like to highlight here is case histories. For each domain, I would encourage you to have at least 2 case histories if you can. Essentially, what I would say a case history is, how I defined it and how I did mine was, you look at a case and literally follow the journey of that case. So let's give an example. To give an example, let's say you have a patient who is in palliative or end of life care, and you've seen that patient. You have the clinical notes for the patient. Maybe referrals were done. You have the referral letter, and then an MDT discussion was done. You were part of the MDT. You went for the MDT. There are minutes of the meeting that shows that you were in the meeting and your contribution, and then you communicated with the family, then you did a reflection, and then maybe you did a presentation. If you put all that information together as one evidence, it's a powerful piece of evidence. And for me, I submitted several of those kind of case histories, and when I got the feedback from GNC, they actually highlighted that was quite impressive, that there were several case histories that they could follow. They could see how I followed the case from one step to the next step and completely, manage the case, and was part of the MDT. And that kind of case history, you can put it for different domains. You can put it in patient management, you can put it in communication, you can put it in safeguarding, as you see relevant. So usually I would encourage do at least 2 for each domain if you can. That shows how you've managed and followed through one patient in different aspects of the management. And the next set of information, documentation you can have, MDT meetings. So if you go to 2, MDT meetings, that you've attended, like all the radiology meetings, track meetings, all those kind of things. That will be one document. Then patient feedback, your multi-source feedback, thank you notes, cards, emails, and so on. I submitted an email from a patient. It was a very lovely email that a patient sent through PALS, and actually had the picture of the child and the family and everything and thanking me. Of course, I anonymized all the information, but I put that email as feedback. And again, when I got my feedback, when my CESR was successful and I got the feedback from GMC, they commented on that email as well that there was very positive patient feedback. So all the patients that are very thankful and say nice things to you, you can tell them to say the nice things via PALS, and you include that in your when you're submitting as part of your documents. Then also aim to do 2 to 3 high quality handover assessment tools. So of course, you all do handovers. Every day you do handover, you don't even think about it. Get somebody to sign off that you were able to, that you can do handovers and give feedback on your communication. And then discussion of correspondence. Discussion of correspondence is what you do with any documentation about correspondence, like your referral letters, discharge letters, clinic letters. Get a consultant or somebody else to look at it and do a doc. I'm sure many of you are familiar with doing docs. You've done it for junior colleagues. Get somebody to do for you as well, and that will be a good piece of evidence. And then reflections and CBDs. So this is by no means an exhaustive list, but this was how I sort of organized my documents within domain 2. So I'll go back to it, starting from organization. So clinic letters, referral letters, discharge summaries, clinical correspondence, my case histories, medical reports, MDT meetings, patient feedback, hacks, docs, reflections, and CBDs. Once I had grouped all my evidence in domain 2 within these categories, I was done, and it was enough to submit. So I have some more top tips for you here. So be intentional. Every day at work should create at least one piece of evidence. And anybody who is doing CESR who chats with me, I always tell them, every day, make sure you're getting one piece of evidence, because every day you're gathering your portfolio together, essentially. And then another very important thing is that you need to create a cross-reference table for each domain. I'll show you what a cross-reference table looks like somewhere down at the bottom. The importance of this, it not only helps you, it also helps your assessor when they're your advisor, when they are looking through your documents. It just makes it clear to them where what is. And if you can, get a testimonial on your communication skills. In fact, all the domains, if you want to, you can get testimonials. So for instance, you've done a beautiful presentation. The feedback was very good. You've done your teaching, you've got the presentation. Remember, we're talking about communication. You've done the teaching, you've got the feedback from colleagues, said, oh, your presentation was fantastic. Get one of the consultants to write a testimonial and talk about how good a communicator you are. And that supports your evidence significantly. And I just want to say that CESR takes time and effort. It takes a lot of grit and a little bit of OCD to get things done. So that's another tip for you. Now, moving on to patient management, which is domain 4. Again, I've put what I've cut and pasted, what I've cut from the specialty specific guidance. This is all that they're asking for in domain 4. And it's just those 5 bullet points that you can see there. And they've given suggested evidence on the right-hand side. I'm sure you've all come across this. Now, I've broken down this and summarized this. So essentially, the types of evidence that they're looking for in domain 4, again, is very similar to domain 2. They want clinical correspondence, they want medical reports, case histories, discharge summaries that shows a wide variety of cases. They want things about MDT meetings, CBDs, mini KECs, HART. Again, it's almost very similar. But the important thing to note here is that they want clinical notes. And the clinical notes they want is actually like your clinical notes. So let's say you clerked a patient, that's your clerking, they want it. So my tip to you here would be, as you're seeing patients, particularly the complex ones, your clinical notes, take note of them and store it somewhere. Of course, anonymize the data and then store it somewhere so that when it's time, you have those notes. So for instance, to give you an example, let me say I see a child with DKA who comes in severe DKA. I've seen them in resource. They are very unwell. We've done all the ABCD. We've brought them out of DKA, and then we later admit them to the ward. as a clinical note, I will keep all that A&E resource information as one document. And then when they get admitted to the ward, if I'm still involved in their management, how they were managed day to day, I'll write a reflection on that. And then by the time they are being discharged, if perhaps I was again involved when they were being discharged and there was teaching and communication to the family, I'll write maybe a discussion or correspondence on that to say how I taught them about how to do their glucose monitoring and all those things. And then I'll put all those three things together as one evidence. My A&E resuscitation, management on the ward, and then discussion about management of their blood glucose levels and education, patient education. I'll put it all together as one document, and that is a powerful piece of evidence. And you can do that across different domains in different ways that you want. So some things I want to highlight about domain 4 is that in domain 4, again, quality over quantity. But what they want to really assess in domain 4 is the quality and breadth of your management of patients as a general pediatrician. So my suggestion would be cover things in all the different areas of pediatrics. So look at all the different systems and make sure that you have something for each system. So for instance, in respiratory, you can talk about a management of severe bronchiolitis. In diabetes, maybe severe DKA. If you've managed a patient with functional abdominal pain or something, that can come under gastroenterology or mental health if you choose to. If you've managed in emergency pediatrics, maybe sepsis or trauma. So try and cover all the different areas. Sometimes because of the work you do, or maybe the hospital you're working, you may end up doing just certain things. So you may end up doing maybe just oncology cases. If you do only oncology, it doesn't show the breadth and range of pediatric cases that you've managed. So just try to make sure that you've covered all the various areas. It's quite important. And what I did was, in my case, for domain 4 patient management, I actually had a list of all the systems. And then I was putting like a tally, how many CBDs or reflections or things I had done in each system. And I noticed I was doing a lot of respiratory system and I was not doing some other systems, like I wasn't doing too much in community and neurodevelopment. So once I realized that I need to do a bit more community, and I had a plan of how I was going to attend community clinics and get that community experience and exposure and put that in so that it shows that you've covered quite a wide range. Otherwise, your experience would look a little bit narrowed. So that's the only thing I will say about domain 4. But otherwise, in terms of gathering the organizing the evidence is still very similar. Again, it's clinic letters, clinical notes, discharge summaries, your clinical correspondence, case histories. Again, I'll say do at least 2 case histories. Just please move to the next slide. Do at least 2 case histories if you can. And if you go down again to the next slide, it's very similar, the categories of things you need to do. So you just choose what categories, MDT meetings. So it's quite similar, radiology meetings and so on, ACAT. And an example of an ACAT could be like you leading a resource, again, handover assessment tools, because it's all part of patient management. And sometimes you can actually cross-reference. So having said that, I'll come to the cross-reference document that I was talking about. So with the cross-reference, this is an example. So you know how in the specialty specific guidance, they talk about the knowledge, skills, and experience. So you put that, you can create your own table, the best way you think is best. But this is an example that you could use. You put that, and then the suggested evidence, then you write the evidence that you have provided in the domain. And if you provided relevant evidence somewhere else, you put it and you put the pages. So let's look at, this is an example of domain 4. So in the first column, what they want, the knowledge, skills, and experience requested is they want that you can assess the evidence base for treatment and assessment strategies, their limitations, and when to act outside them with appropriate advice. That's what they want. And the suggested evidence they've asked for is discharge summaries. Now, within this domain, I haven't provided any evidence, but in domain 2, I've provided an evidence which I've titled Discharge Summaries Complex Cases STGH, pages 1 to 17, which means that for this knowledge, skills, for this KSE that they want, I have provided the evidence in domain 2 and I'm cross-referencing it to domain 2. Then the next thing they've asked for, another suggested evidence, is case histories. And I've put here, I've provided evidence. My evidence is titled Severe DKA Management 2024. So that's the evidence I've provided. If they go there, they'll see that I've covered this KSC that has been requested for. Another evidence, suggested evidence, is clinical correspondence. And then I've put there that the evidence I've provided is neurology emails FND. My thing is titled neurology emails FND, whatever you decide to call it. So this cross-reference table, you need to do it for each domain because it makes it easy for you to see what information you've provided and also okay, sorry. Let me put my camera on. So it makes it easy for you to see what evidence you've provided and also helps your advisor, your assessor to clearly see the evidences that you've provided. So having said that, I think that's all I will take for now. And then just to conclude and summarize, I've talked about quite a few things. Essentially, I talked about organizing all your evidence into relevant folders. After organizing into the folders, then grouping your evidences, aiming for 12 to 15 categories in each domain. Look at quality over quantity, aim to get something every single day, and then redact the documents as you receive them and create a cross-reference table for each domain. So I would stop there 2 minutes before my time is up, and then we'll take questions at this point. That's my name, my email address. If you wish to contact me, I'm happy to help you at any point in time if you send me an email. Thank you.
That's lovely. Thanks so much, Naomi. There's lots of questions actually, a few that I could help with, but mostly they're quite specific. Well, better for someone who's completed the process. So if I can read them out for you in probably in order or so, but then can I also, in the break, I'll put the survey back in the chat, and it would be really amazing if maybe even just like another 10 or so people could fill, just so that we know a bit more about you and if this session is delivering like on the outcomes. So only 15 people have been able to fill it. So it'd be really lovely if a few more of you who are here today could fill it in during the break. So basically to go on to questions, oh, and Jazz is here too, so you can answer together. Maybe we'll go backwards from the end because that will be easier for me. So yeah, this is going to be recorded, so it will be on our YouTube channel. One thing was about, oh, now loads of questions are coming, which is good. So there was a question about how to collect like discharge summaries and things. Someone was asking, can they do a screenshot and print and redact? And I was concerned that potentially, like in terms of information governance, what's your best practice advice in terms of collecting this patient information that has obviously the patient details on it onto a private device, which is your owned private device, and then later on redacting it all in one big go, which is obviously more efficient and practical. But what would be your advice about the information governance?
My personal advice.
The actor is asking that actually, because she's obviously thought about it in quite a lot of detail.
Okay. My advice, and this is because it was a lot of stress for me when I had to redact all the things. I gathered all the things and then tried to do all the redaction in one go. My advice would be redact on as you go along. Therefore, if you're in the hospital, find out how you can download that document and redact it on the hospital computer if possible, so that what you then send to yourself is redacted information. You haven't got any patient information details just because of information governance. That's my suggestion. But I don't know what Jazz or other people think.
How would you redact it in the hospital?
So you need to buy. So for me, I got one of the admin staff to help me. She had like a redaction tool.
Oh,
And so,
amazing. So
yeah.
that's the
So,
ideal
yeah.
scenario.
Yeah. So it was redacted in hospital. And all I got was the redacted data. So if that's a possibility, see if you can do that. But if you can't, then you would have to download it onto your private document and redact it and save on your documents, on your computer, sorry. I don't know,
Okay.
Jazz, do you have any thoughts on that?
It's quite,
So I didn't get any. I made the same mistake as Naomi. I collected everything and redacted it one go. There are advantages to that, but looking back, there are ways we could have made it easier. I didn't pay for Adobe. What I did is I used the 2 weeks free, and then I subscribed for 1 month, but I then stopped my subscription before the 1 month was over. So I got my money back. So basically I used 6 weeks of free Adobe without actually paying. So you need to be smart about this. If you don't have admin support from the hospital you're working in, which was my case, I did it myself. But again, you have to be practical. If you're collecting your evidence, for example, over 1 or 2 or 3 years, and you want to redact daily and you're paying from your own pocket, you're going to raise a bill for yourself. And if you want to save that cost, then one way of doing it, use what Naomi is saying. Instead of redacting with a permanent tool, you can highlight the areas that you need to redact. So it's almost done for you. And you just take the PDF or the Adobe thing for subscription for free, and then just look at the areas you've already highlighted and then redact them permanently. It is double work. So it's about costs versus adding some additional workload for you. You'll have to decide what's best for you. That's what I advise.
Great.
Thank you.
And then there was a question about for pediatric intensive care portfolio pathway CESR. So for all the subspecialties, I know there's someone with neonatal question as well who's joined today. Any specific advice? I think in general, all the evidence collection will be the same. So I think this highly relevant, but in terms of specific guidance, there is a PICM advanced CESR video on our YouTube channel, on the Soft Landing YouTube channel, that was before the change, or sorry, around the change time in 29th November 2023, 24. So that could be useful, but obviously all the evidence collecting and redact the process is exactly the same. But I've said that to contact the ISAC or the CSAC for PICM and check with their particular SSG what they're asking, what curriculum they're setting, because it will be different for neonates and PICM and things like that. Anything to add on that? I'll move on to the next question. I think it's nice because we're quite a big group. It's nice to just do these questions from the chat, and then for the final Q&A, we can maybe open the floor and let people speak themselves. I know, Tammy, you had your hand up, and it would be super helpful if you just put the question in the chat for this section, just so that we keep to time, and then at the end we can let people unmute, because it is nice to hear from you. So the other question was about, can you collect evidence retrospectively?
Yeah,
And
you
how
can.
exactly would you do that? For instance, I guess if you had a really good case that, or like, there was a CDOP that you went to 6 months ago, but or you had a good resus or something like that, or a good meeting, I suppose, that you chaired, you presented in your M&M or something, but you didn't collect evidence at the time.
You can. So my suggestion would be, if you're going retrospectively and you're going really far back, probably better to do a reflection. So you can put the date of the reflection, the date the event occurred, and then write your reflection. If you're going to do a CBD, the CBD you would be doing on the portfolio, isn't it? So if you're putting that this event occurred 6 months ago, and then I'm only doing the CBD now, it doesn't look too good. So probably do a reflection. A reflection really is like a CBD, just that you're doing it by yourself.
Okay,
So
good.
for
And
those
that
kind of
leads,
things.
yeah, and that leads
Yeah.
nicely on to another question, which was about, is reflection enough to evidence a meeting? And I was saying, I think probably as part of all your evidence, it's fine. But if everything is just reflections, then it wouldn't be
Yeah.
fine.
You need a variety of things. So just a reflection, or just reflections only, your as your evidence won't be sufficient. You need a mix of things. You need reflections, CBDs, hearts, different things. But however, for like meetings, I would suggest do a reflection, and then if you have the minutes of the meeting, attach that as well, because then it shows. You want to show primary and secondary evidence. Primary evidence is that you've done something, you say you've done something. Secondary evidence is that somebody confirms that, yes, you've done it and you've done it well, or you've not done it well. And you want to show that you've done things in different settings. So for instance, if you've been to a meeting, you've done your reflection on the meeting, you've shown the minutes of the meeting, and maybe your reflection, you've written that, oh, actually, I didn't know this and I want to learn a bit more about this, and you've learned more about that, then you show that you've learned more about that, and you put all that together as one evidence.
And I think it was nice how you highlighted about the cases where you sort of followed the whole journey of the patient. And I think that maybe has made someone anxious, because there's a question about, is it compulsory to be involved in every part of the patient's journey to use
No,
evidence? And of
no,
course, no.
no.
But maybe like if you could have at least one case where you showed that, it sounds like that did go down very well. How did you manage to be involved for the whole patient journey, or was it that you identified them early on as this is, or did you kind of look back and think, oh, I'll actually put that together?
I think so. The one that readily comes to mind was one who I attended the child death review meeting for, and it was an oncology child. I was
Mm.
involved in their care when they came for like blood transfusions and so on. Then subsequently their cancer progressed, and then they went into palliative care, and I was involved in their managing them when they were in palliative care. And unfortunately, they passed on, and I heard about the review, the CDRM that was ongoing, and I requested to participate in the CDRM. And therefore, I was involved in a wide for the journey of that patient, and I wrote a beautiful reflection along the pathway showing my involvement. So that was quite a good piece of evidence. And you don't have to, you don't have to be involved in every single part of the journey. But if you can show your involvement in like maybe two bits of the journey, as it were, and what further things you did. I'll give an example. Let me give an example of, let's say, a child came in DKA. DKA is something that I kind of commonly see, and you manage them in A&E when they came in DKA. You've done a reflection on your acute management. Maybe you do an ACAT or something for that case, and then the child goes to the ward, and perhaps when they were being discharged or something, you were there, and you were there when they were being taught about how to use insulin and so on, and you write a reflection on that as well. That piece of evidence together, your ACAT, your reflection, and then maybe you go for a training on diabetes. You go for like a study day or something. The reflection from that study day and your learning, all that evidence together is a powerful piece of evidence to show how you understand the management of DKA, for instance, across different across different settings. So you don't have to be involved. Don't get nervous. I don't want you to leave this meeting nervous at all. Don't get nervous. You don't have to do it. But if you can, it's a good piece of evidence to have.
Yeah, I think that was the question as well. How do we show we were actively involved? Like, because obviously in your example, that's a lot of MDT, lots of different people would have been involved. How did you demonstrate your own personal involvement? And I guess you've already answered really. You said by reflections, and I guess I don't know if you presented the case, but you might have
No,
included
I didn't. I
presentation.
didn't present that case, but a presentation is also a good thing. I
Mm,
managed this patient. I presented the case to colleagues. This was the feedback. It's a very good piece of evidence.
mm. So in that case that you told, it was mainly reflection that you showed your
Yeah.
management.
Yeah. It was
So
reflections
those,
and then the
yeah.
minutes of meetings.
It sounds to me like what, and just that you were there at the meeting, just that you were an attendee at the meeting, and that was evidence.
Yeah.
You didn't have to be chairing, you didn't have to be presenting.
Yeah.
I think
Yeah.
that's the main thing that I'm getting from you, that being part of the team involved and a reflection alongside. If you
Yeah.
weren't super active, like obviously chairing the meeting or something, then that is good evidence. And
Yeah.
then we're coming towards maybe the last couple of questions, and we have got half an hour at the end and some time on in Jazz's section for questions as well, so don't worry. But it might be nice to just have about procedures. So two questions that are kind of related. One's about what portfolio did you use, and if you used RCPCHE portfolio, can you then use it? Can you do all that stuff on RCPCHE portfolio, like the docs, the KEX, the CBD? Or
Yeah.
what did you
Yeah.
do?
I use the RCPCHE portfolio, but then like I said, the two systems don't speak to each other. So anything you have on RCPCHE portfolio is not going to be transferred to the GMC. You need to download and upload. So what I then did when I realized that I needed to do that, as I was getting evidences done, like my CBDs, hearts, blah blah, on the e-portfolio, I would download it and save it in the relevant folder.
Mm.
So if I did a CBD on communication, I'll quickly put it in communications folder, download and put, and then upload it to the GMC.
Yeah, and so then it's quite easy, I guess, if you have RCPCH portfolio, because for instance, another question about LPs and procedures, how should
Yeah.
they evidence those? Does it have to be a consultant who signs those?
So with procedures, I would say you should definitely have procedures that you've had DOPS for, so that you've been observed. And then once you've been signed off that you're competent to do these procedures, what I did was I started creating a log of all the procedures I was doing to show that I was maintaining my competencies, because I'd been competent in the procedures from maybe 5 years back. But to
Mm,
show that I was continuously doing the procedures, I created a logbook. So I had a log of all the LPs I've done. Of course, it's not every single LP, but the difficult ones or something.
mm,
So at least every 2, 3 months, I would say, oh, I did a very difficult LP for a 10-year-old. It was a difficult procedure. Parents were anxious, blah, blah. I'll write something in my logbook. So if you saw my logbook, you could see that my competencies were up to date.
And how did you make your logbook? Was it in like
Just
Excel?
Word. No, Word. I just created
Just
a
a
Word
Word document.
document.
Oh, so
Yeah,
like a
just a Word
table.
document. Yeah, like a table.
Oh,
Yeah,
okay,
yeah,
that's good.
yeah.
Okay.
I can't share my screen. I would have shown you what it looked like.
Okay.
Yeah.
All right. So if to allow for a 5-minute comfort break, we can have a quick break now, and then I know you've allowed them 10 minutes, but I was going to say, so many questions. It would be nice to get into Jazz's section and then have plenty of time at the end for the questions, because there are, there's people have lots of
I
questions.
can see a question just popped up.
And
Somebody said,
feel
was a
free to
logbook
answer
shared
anything.
by anybody? Was signed by anybody? Sorry. No, it wasn't signed. It was just me. I was documenting. I didn't sign it. Nobody signed it for me. It
They'll
was
believe you.
once you've been approved to be competent in that procedure, nobody really needs to sign or check for you anymore.
Yeah, and I guess also if you teach the procedure, that would be a nice. You
Exactly.
could
Yeah.
put that as somehow like
Yeah. Yeah.
in RCPCH portfolio. There's a teaching like way
Exactly.
of document like evidence,
Yeah.
but recording the teaching or
Yeah.
getting the feedbacks of teaching.